So good morning, everyone. So this lecture is on BIRADS mammography, and you all very acknowledge of the fact that mammography is the only breast imaging modality that has shown through the years that it decreases the mortality rate. And mammography is used mainly for screening as well as for diagnostic breast imaging. All this information will be given to you, or maybe it's already given to you, all these lectures. So in order to keep clarity in our reports, the ACR BIRADS has been developed, which is a quality assurance tool to standardize reporting in order to reduce confusion in imaging interpretation, to have better communication among radiologists as well as with the clinicians, and also to facilitate outcomes monitoring. And the learning objectives of my lecture is to present to you the description of terms and definitions, the report organization. I will talk to you about the reporting assessment categories, about the management, and I'll close up with take-home messages. This is the table of contents as it appears in the BIRADS Lexicon for Mammography in the 5th edition, where it consists, the section 1 consists of these main entities, where we'll talk about the masses, calcifications, architectural distortions, asymmetries, intermammary lymph nodes, skin lesions, and solitary dilated ducts. Now, in the recent 5th edition, associated features as well as the location of the lesion are very well described and have been included. So the first term is mass, or masses. A true mass is a three-dimensional lesion that occupies a space. It is completely or partially convex outward borders and is seen in two different mammographic projections. Now, the morphological descriptors that are used to classify masses is the shape, the margin. The margin is the edge or the border of the mass, and the density, which is defined as the X-ray attenuation of the mass relative to adjacent tissue. Masses, the shape of the masses are classified into the oval shape, round shape, or irregular, and the margins, they might be circumscribed, obscured, microlobulated, indistinct, or spiculated. And the density, masses may appear as high density, equal density in relation to the adjacent breast tissue, as low density, or fat-containing masses. And benign masses might be round or oval in shape. They must be well circumscribed, and they might appear with fat-containing or low density. These are examples of circumscribed masses. You can see on the left image here, oval masses, round masses, masses with fat within them, and also masses with equal density. Indeed, masses that are obscured is the term that it means that the mass is hidden either by the adjacent fibroglandular tissue, or it is just, you do not identify 75% of the margin of the mass. Now, masses that are suggesting of being malignant are masses that appear with irregular shape, that have microlobulated, indistinct, or spiculated margins. And these here are some examples. Irregular, you see here, let me find the laser. Irregular mass, microlobulated, spiculated, indistinct mass in the bottom, and here is an increased density mass. Now, the other term we'll speak about are calcifications. Calcifications are very important because it is a finding that is very frequently identified, visualized on mammography, and it's important to be able to distinguish benign from malignant in order to reduce our false positive findings, false positive rate. And mammography and calcifications might be just typical benign that do not need any further evaluation. And this is a list of the typical benign calcifications. You're all very familiar with this. And these are examples, different cases, calcifications, rod-like shape, round calcifications, popcorn-like calcifications, rim, and dystrophic calcifications. Now, what about the milk of calcium calcifications? These are typical benign calcifications, do not need a short follow-up, but in order to define the milk of calcium calcifications, you must proceed with a spot magnification view in 90 meters. This is very important, so further evaluation is needed. This cannot be defined and assessed just in screening. Punctuate calcifications are defined as calcifications are very tiny, less than 0.5 millimeter. They might appear as a group of punctuate calcifications, and they are defined as probably benign, which is BIRADS 3, if we do not have a prior examination or if they are stable for at least 3 years on mammography. Further evaluation of this type of calcifications is needed if they are new, if they have increased in number and they have linear or segmental distribution, or if they are located near adjacent to a known cancer. And this is what they look like. I hope you can all see them because some of you are sitting in the back. They're typical benign. Now, suspicious calcifications are calcifications that have amorphous morphology. They're coarse heterogeneous, they're fine pleomorphic, or fine linear, or fine linear branching type. And here is an example of amorphous calcifications. The positive predictive value for malignancy in this type of calcifications is 20%. Coarse heterogeneous calcifications are defined as calcifications with irregular conspicuous morphology. They're very small, between 0.5 millimeter to 1 millimeter. The positive predictive value for malignancy in this type is less than 15%, and they're categorized as BIRADS 4B. And here's an example of fine pleomorphic calcifications. They're irregular in shape. The positive predictive value for malignancy reaches up to 29%. And this is an example of a fine linear branching calcifications. You can see an example here. The positive predictive value is increased up to 70%. They're highly suspicious. It's a BIRADS 4C category. The distribution is another important criteria that you should always evaluate whenever you detect calcifications. It actually describes the arrangement of calcifications in the breast, and it is recognized, it is divided to segmental, linear, grouped, regional, or diffuse. Now, diffuse or scattered calcifications are typically benign, and you can see here that the positive predictive value for malignancy increases from regional to group to linear to segmental. So segmental has the highest positive predictive value. Here you can see the arrangement of calcifications in the breast, the diffuse, the regional, the group, and the linear. And what is the definition of a group of calcifications? There are calcifications, it is defined as calcifications that are located in a region of the breast that is less than 2 centimeters. It's usually about 1 centimeter, but it's usually then 2 centimeters. And the regional calcifications are defined as the ones that are located in an area of the breast that is larger than 2 centimeters. These are regional calcifications, and this is a group of calcifications. You can see the small area of the breast. It is just tiny. Linear distribution is another descriptor, so please, again, keep in mind, except the morphology, the distribution should always be taken into consideration. Segmental distribution also might represent a suspicious finding, should always, again, taking into consideration before classifying your calcifications, and it might suggest deposits of calcifications in a duct or ducts and their branches, even if they are amorphous. Even if you have amorphous calcification or punctuate, should always raise suspicion when the distribution is segmental. Our next entity is architectural distortion, where the parenchyma is distorted without the appearance of a definite mass, and further diagnostic evaluation is always needed with additional mammographic views with DBD or ultrasound. It depends what is available in your practice or in your hospital. Remember that in the absence of a trauma or surgery, architectural distortion should always be considered as a suspicious finding for malignancy or even radial scar, and tissue diagnosis is necessary. Asymmetries is another entity, very challenging for radiologists. They are subclassified into asymmetry. It is seen in only one view, as you can see here on the MLO view. It's not visualized on the CC view. Additional mammographic views should be obtained to establish or exclude the diagnosis of summation artifact or of superimposition of normal breast tissue. Global asymmetry is defined as asymmetry, as global asymmetry, as you can see here. It occupies, this density occupies at least one quadrant, and focal asymmetry, it's seen in two views, but it occupies an area of the breast that is less than a quadrant. The likelihood of malignancy in focal asymmetry, note that it's very low. However, further evaluation is needed to exclude the possibility of malignancy. Developing asymmetry is the most important one. If it is new or increased in size, it should be always considered suspicious. Further evaluation is needed, not unless your patient recalls of having a trauma or has been injured in this area or has an inflammation, but further evaluation is mandatory because it might represent a new small cancer, and it is categorized as BIRADS 4. Intramammary lymph nodes, you're all very familiar. They're usually less than 1 centimeter in size. You can recognize the fatty hilum whenever you have an enlarged intramammary lymph nodes larger than 1 centimeter, and it represents an ultrasound hypoechoic mass that is round with increased vascularity. Further evaluation is needed. Skin lesions should be always localized by your techs, so we are not confused that they are real findings within the breast. Solitary dilated duct has been upgraded because in the 5th edition it has been considered that there is a risk of 10% of malignancy, and histological examination is needed. Additionally, the associated features are included in the 5th edition, and this chapter includes the skin retraction, nipple retraction, skin thickening, trabecular thickening, axillary adenopathy, architectural distortion, and calcifications. Skin thickening, you can all see the mass and the thickening of the breast. Nipple retraction, if it was not there for many years, it is a highly suspicious finding. It might represent a mass that is just hidden under the area under the nipple, so it should always be further evaluated. Skin thickening is defined as an increase of the skin more than 2 to 3 millimeters. It might be diffuse or local. Further evaluation is needed, and always please remember to compare with previous examinations because you find this very important in order to differentiate from just a finding that was there for many years. It is normal to see increase in thickness of the breast, of the skin, 2 to 3 millimeters in the area of the inframammary fold or in the area around the nipple. What about trabecular thickening? Trabecular thickening appears as increased density in mammography, and in most of the cases it represents edema that has been developed due to different different reasons. It might represent an inflammatory cancer, simple mastitis, just in other cases, post-radiation changes, but further evaluation of these patients is needed whenever this patient comes to you at your center. If you have previous examinations, so you can see that it is just to edema due to post-operative changes or to post-radiation and should decrease through time. Axillary adenopathy is also included in the associated features. In the absence of a known inflammatory cause, isolated axillary adenopathy should receive a BIRADS for assessment. However, in screening, a solitary, just an axillary adenopathy is classified as BIRADS 0 because it needs further evaluation. We spoke about architectural distortion. More architectural distortions are recognized with DBD, with tomosynthesis. Report organization is very important. Please, whenever you find the lesion, define exactly, then describe exactly the location using a standard plaque face orientation. It's very important for the clinicians and also for following up these patients. Also, we have to describe the overall breast composition, and we have 4 different patterns, ACRA, B, C, and D, and you're all familiar with this, so I want to save some time. And currently, 38 states in the States mandate some level of density reporting. So in Connecticut, it was the first state to pass ALOI 2009. Here we don't have, we don't face such problem in Greece because we have opportunistic screening. So in women with dense breast, we always perform additional breast ultrasound. So clear description of any important findings is mandatory. If you find a mass, describe all these criteria: calcifications, architectural distortions, asymmetries, intramammary lymph node skin lesions. And we can proceed now with the BIRADS assessment categories. BIRADS 0 is considered to be incomplete. Maybe you need prior examinations to be sent to you. This should be sent within 30 days, or you might need additional breast imaging, which needs the use of spot compression or special mammographic views or further evaluation with breast ultrasound or MRI. In BIRADS 1, we do not have anything to report. In BIRADS 2 are all these benign findings. BIRADS 3 is recognized as the most challenging BIRADS assessment category as probable benign, which needs follow-up after 6 months interval with mammography, and then periodic mammographic follow-up are included lesions that are non-calcified, well circumscribed, which are new, a focal asymmetry that spreads out with spot compression views, or solitary group of punctuate calcifications if there is no prior mammography available. This is the algorithm. You can find this in your notes and read it at home. And BIRADS 4A is considered to be low suspicion of malignancy, less than 10%. Remember that you must be very careful when categorizing. Think about all the skills and the expertise you have, because it's important not to underestimate a lesion, and it's also important not to send a lot of patients to biopsy without reason, as 4B are classified amorphous calcifications, the fine pleomorphic, the heterogeneous, and also the partly circumscribed and partly indistinct mass. 4C, the results of a biopsy in this category should expect malignancy, and if the biopsy results are negative, a further surgical biopsy is indicated. BIRADS 5 is a category that we include findings that are highly suggestive of malignancy with probability of more than 95%. Here are the regular speculated high-density masses with associated calcifications or newly found linear branching calcifications in segmental distribution. And you all know the BIRADS 6. It is defined as, in this category, a cancer that has been already known, has been biopsy proven for malignancy. Of course, there must be, this is very important, you must always be concordant between your imaging findings and BIRADS assessment categories and management recommendations. And I would like to wrap up just saying that it is important whenever you don't remember, because we are human, we forget, we're overloaded with with a lot of information. Keep the atlas at your office, or maybe you can have, it's possible now to have the web-based format at work. So you just go back and look. And take-home messages is that ACR has developed the BIRADS to standardize terminology and reporting of mammography, to clarify our reports, to have better and clear communication, to facilitate outcomes and monitoring, and to ensure our patients the best quality in management and treatment. And remember that medicine, and especially BIRADS, is like a puzzle. You take the information and you just connect it, link it together in order to conclude for our patients' best outcome. I would like to thank you all for your attention and to wish you a wonderful day. We do not have any, we're running late already, we're 5 minutes, so I would like to call Dr. Ellen Mendelsohn for the next lecture. Thank you so much.